The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. I would like to welcome you to this afternoon's webinar, Quality Healthcare for Lesbian, Gay, Bisexual, and Transgender People, a four-part webinar series. In today's webinar is Part 1, Understanding the Health Needs of LGBT People, an Introduction. My name is Cherie Wilson, and I am a Faculty Research Associate and a Program Director in the Hopkins Center for Health Disparity Solutions in the Johns Hopkins Bloomberg School of Public Health. Let me start with a few housekeeping rules. If you experience any technical difficulties, please contact GoToMeeting customer support at either 1-888-259-8414 or at 1-805-617-7002. In order to have complete audio capabilities, including the ability to verbally ask questions during the Q&A session, if you are joining us by telephone, please enter the audio pin which appears when you log into GoToMeeting. During the webinar, all attendees are muted. In addition, to be recorded as a participant, you will need to click on the GoToMeeting link that you received in your email in order to access the system. Otherwise, the system does not record your attendance. Lastly, feel free to submit questions at any time during the webinar. This webinar is being recorded, and the recording and presentation slides will be available on the GLMA, Center for Health Disparity Solutions, and Culture Quality Collaborative websites after the webinar. So first, let me tell you about the center. We are the Hopkins Center for Health Disparity Solutions, and we are a research unit of the Johns Hopkins Bloomberg School of Public Health. Dr. Thomas Levice founded the center in 2002, which is a National Center of Excellence in Health Disparities Research, designated by the National Institutes of Health, National Institute on Minority Health and Health Disparities. We are very pleased to partner with GLMA to offer the first in the four-part webinar series. Our center also provides a web-based organizational cultural competency assessment tool called the Cultural Competency Organizational Assessment 360, or the COA 360. In addition, we host a membership group of healthcare organizations working in concert with the center faculty and select cultural competency consultants to improve the organizational cultural competency efforts of our organizations through webinars and assessments. If you'd like to learn more about either program, I'd encourage you to participate in next week's webinar called A Continuous Quality Improvement Approach to Organizational Cultural Competence. And if you'd like to participate, please feel free to email me directly for more details. And now I would like to turn the presentation over to Hector Vargas, who is the Executive Director of GLMA.
Good afternoon, everybody, and welcome to our webinar series. I want to thank all of you for taking the time today to be a part of this important launch, and especially to thank Cherie Wilson and the Johns Hopkins Center for Health Disparity Solutions for their great partnership on this effort. For more than 30 years, GLMA has worked with its members from across the country and across the health professions to ensure equality in healthcare for LGBT individuals, families, and healthcare professionals. GLMA's members are physicians, physician assistants, nurses, advanced practice nurses, behavioral health specialists, researchers, students, and administrators, among many other professions. GLMA works to achieve our mission of equality by using the expertise of our professional membership to advance public policy work, provide patient education and referrals, to promote research, and to design professional education programs like the webinar series that we're doing today, and also like GLMA's annual conference, which is celebrating its 30th anniversary this September. We hope you can all make it to our conference. To lessen the negative consequences of discrimination and stigma, and to reduce health disparities based on sexual orientation and gender identity, healthcare professionals must become more inclusive and responsive to the needs of the LGBT population, and their care must be culturally competent. Although this is changing due to the efforts of many people, we know that many health professional schools are not adequately preparing future healthcare providers with the skills, knowledge, and attitudes necessary to provide appropriate care to the LGBT community. And that's why this webinar series is so important and actually quite timely given the announcement today by the U.S. Department of Health and Human Services in which they delivered their 9 priorities to address LGBT health for 2012. And one of those priorities is clearly about improving access to culturally competent resources and training for healthcare professionals. And so with that, it is my pleasure to introduce our presenters today, Gall Mayer and Jason Schneider. Gall is the medical director of Callen-Lorde Community Health Center, which provides healthcare services to the LGBT community in New York City. And Jason is an assistant professor of medicine at the Emory School of Medicine. Both Jason and Gall are GLMA board members, and Jason is a past president of the organization. And with that, I'm turning it over to Gall.
Good afternoon, everyone. Thank you for joining us. This is Gall Mayer speaking. I'd like to start by just letting everyone know that we have no disclosures or conflicts of interest to report to this audience. Today's learning objectives, as you probably know from the announcement, are to be able to define the terminology and describe the concepts associated with LGBT populations, describe the ways in which marginalization and discrimination impact the health of LGBT people, and to discuss some of the specific health disparities experienced by LGBT people. We're going to begin our presentation with, this is an introductory module to the rest of the webinar series. And so we begin with very basic concepts of definitions and LGBT terminology so we can all be on the same page in terms of what we're talking about. So LGBT is an acronym that stands for lesbian, gay, bisexual, and transgender. We use it as an umbrella term to describe all the sexual and gender minorities. There are often other sexual minorities that are included under here that would identify differently, like people who identify as queer or questioning, but we're just using LGBT as shorthand to identify everyone. And it's important to remember that there's a tremendous amount of diversity within each of those groups in terms of race, ethnicity, socioeconomic status, their geographic location, and age. So I think it's really important to start our discussion with a little bit of basic understanding about gender. When we talk about gender, we're not talking about sex, which is a male or female that's determined by chromosomes and anatomy. And also gender is very different from sexual orientation. Gender has several components. The first is gender identity, which is an internal psychological awareness or sense of where a person fits on the man-woman spectrum. And I always give as an example that no matter what your body looked like when you look in the mirror, your sense of who you are will never change, your internal sense of who you are and what gender you are. And that's your gender identity. Then there's gender expression, which is the way in which everyone communicates his or her gender identity through their appearance and behavior. So all of the decisions that we make about how we look to the world, you know, whether it's makeup, a tie, dress, stockings, long hair, short hair, beard, all those decisions that we think of as very superficial, maybe fashion decisions, are really a way that we're telling the world what do we want the world to know about our internal identity and how we feel about ourselves. And then there's gender role. Gender role is a little bit more complicated, and you know, there is your internal gender identity, and I should say that this is really an introduction to the concept of being transgender. So that's why these components are important. But in addition to your internal gender identity, there is also the gender that the world sees you as. And so if you are perceived to the rest of the world as a man or a boy when you're a child, then you'll be treated like a boy and you'll be socialized like a boy. And even if your internal gender identity is that of a girl, you will internalize some of that socialization, and that will become part of your behavior. And that is the behavior that's influenced by society's expectation of what's appropriate for the gender that society sees you as. So that brings us to the idea of being transgender. So the term transgender can also, there's other terminology that can be used instead: gender variant, gender nonconforming, gender different, and all of these are really umbrella terms that are used to group the many gender different communities. And by that, we are talking about someone whose internal gender identity or gender expression is different from the sex that's assigned to them at birth. So someone who may be born with a boy's body and treated as a boy growing up, but has an internal gender identity of a girl and a woman, and as they grow, they may start to express themselves that way. The word transgender or transsexual can also mean something more specific than that when it's not used as an umbrella term. It can really be used to describe men and women whose gender identity most closely matches the gender, the other gender that they were assigned at birth. So it's very specifically, you know, going back to my example, I was born with a boy's body, but if today I identify as a woman, then I'm transgender, meaning my identity is the opposite of what my body seems to be. And sometimes the word transsexual is used even more specifically to describe a transgender person who has undergone genital surgery. But that's not necessarily the case. Not everyone uses the word transsexual that way. And it's also a little bit of a misunderstanding that all transgender people want to have genital surgery, or what used to be called sex reassignment surgery. That's not necessarily true for every transgender person. And even for the ones that it may be true for, it's not necessarily accessible, as we'll go into in a little bit. And then finally, I think there is a term called genderqueer, which is really before born with a boy's body, today identifies as a woman. Genderqueer might be somebody who was born with any type of body and today does not identify 100% as male or female, or feels like they identify as both or a combination of the two. And genderqueer is a term that's used to describe people who identify that way. There are a couple of other sort of gender variant behavior that can fall under the transgender umbrella, but it's important to talk about them so to help the audience distinguish between them, so as not to confuse these things, because this can be very confusing. So a cross-dresser is somebody who has a desire to wear the clothing of the other sex, but not necessarily to change their gender, or their gender identity may not be different from the body that they were born in. And in fact, a lot of cross-dressers, or what we call cross-dressers, are heterosexual men who cross-dress for erotic arousal. And in some older literature, you'll hear them being called transvestite or transvestic fetish. But there are people who dress in the clothing of the other gender who don't have a gender identity that's different from their body. It's more just about liking to dress that way. And as if that wasn't confusing enough, there is also in the gay and lesbian community these things called the people called drag queens and drag kings. RuPaul is a famous one, but these are individuals who really cross-dress for entertainment purposes, not for erotic arousal, but to make a living or to challenge social stereotypes. And again, they could be a gay man dressing as a woman to put on a show, but may not have a gender identity that is necessarily that of female. So moving on to, that was about gender identity. Moving on to sexual orientation, you know, we often think of sexual orientation with a very simple, you know, are you gay or straight? And we want, it's important for everyone to understand that it's really not that simple, that there's a spectrum here and that there are concepts in sexual orientation having to do with behavior, identity, and orientation and the difference between them and the fact that they can be different. And I'll talk about examples in a minute. So let's start with the first component of sexual orientation, which is sexual attraction. So sexual attraction is really who you are attracted to in your fantasy life. It's something that only you know about. You can choose to tell the world what is in your sexual fantasies, but you don't always. So it's something that's an internal identity. It develops very early as a child, and it's absolutely not a choice. So a little girl can grow up having sexual fantasies or being sexually oriented toward men, toward women, or toward both, and there's no choice over the way that attraction forms. And that's also called your orientation. And then there's behavior. So I think most people understand the concept that just because you are oriented to someone sexually does not mean that you're going to have sex with them. And the behavior is something you have a lot of choice over. You choose who to have sex with. When gay men go through, quote-unquote, being in the closet, they may have sex with women even though that is not what that wouldn't be their first choice for attraction or fantasy. But a lot of times behavior is aligned with sexual attraction, like it is for most heterosexual people, and sometimes it's not. And finally, there's identity. And identity is also something you have complete choice over. It's the label that you choose to call yourself to tell others what you want them to understand about your sexual orientation. So you could identify as a straight person. You could identify as a lesbian. You could identify as a bisexual. And some of those identities may include emotional, social, and lifestyle preferences. But it's important to keep this separate from the sexual attraction and sexual behavior. So as an example, you could be a man who is bisexual, attracted to both men and women, but identifies as a straight person and may be married, but also has sex with men, in addition to being married. So that person's identity would be straight. Their attraction may be bisexual or even gay, and their behavior would be to have sex with both genders. So this is a table that we put together to really summarize everything I've spoken about up until now. We didn't talk about sex specifically, but remember, sex is genetic and anatomic, and you could be male or female or in genetic XY or XX. But it's important to remember that even on that very granular level, sex doesn't just come in two varieties. There are people, as pointed to in the middle of those spectrums, there are people that are born with genetic anomalies that may not be clearly XY or XX, and there are people that are born with anatomic anomalies called ambiguous genitals that may not be clearly male or female. And I think the big lesson here is that nature loves diversity, and it makes absolute sense for these features to have more than just two varieties in nature. And of course, us human beings, we're not that comfortable with diversity, and we like to pigeonhole things, so we tend to ignore or not pay enough attention to the constructs that don't fit into our pigeonholes. But even on a sex level, it doesn't just come in two varieties. And then once you move into gender, identity, role, and expression, it's an absolute spectrum of how you can identify everything from masculine to feminine and everything in between. And then, of course, there's sexuality. Your attraction could be homosexual, bisexual, asexual, heterosexual. Your identity is just a label that you put on yourself, and your behavior can be very separate from those concepts. So with that, I'm going to turn it over to Jason to talk about demographics.
Thanks, Gall, and welcome to everyone. Thank you for joining us for this first of 4 webinars. I'm going to start out by describing some demographics of LGBT people, mostly in North America, but with some references throughout the world. So numbers and the exact prevalence remains unknown. The thing that makes this even more complicated is that measurements vary based on different layers of identity for people. So their country of origin, where they live, their race or ethnicity, the level of education. This is an indication that stigma influences especially identity, but also behavior. This data presented in the table at the bottom is about 20 years old, but it still holds true today. Interestingly, you can see that the prevalence of different same-sex attraction and then identity decreases as different things are layered on top. So the knowledge that you're attracted to someone of the same sex is higher than sexual behavior with another, and even less so when you look at identity. This speaks to the complexity of sexual orientation and that you can't just look at one component to define it. The data supporting prevalence for transgender people is even more limited, and as you can see in this graph, varies based on country of origin, and this also speaks to the level of acceptance and care for transgender people that is available in different countries. There's a bit of a selection bias here, so many times these numbers come from clinics that provide care to transgender people. So the number ranges from anywhere from 1 to 1,500 to 1 in 30,000, as you can see based on the numbers here. We do know a bit more about lesbian, gay, and somewhat about bisexual people in the United States. The 2010 census data is still being analyzed, but we have some very striking data even from back in 2000. We extrapolate from the 2000 census some information about the prevalence of lesbian and gay populations based on the number of same-sex led households. The most fascinating piece of information that came from this census is that 99% of counties in the United States have households with unmarried same-sex partners. Now, the asterisks that you can see indicated on this map indicate where these couples are clustered, and so you can see that on the West Coast, up and down the East Coast, especially in the Northeast and in the South, this is where we would expect most of these same-sex couples to reside. But I emphasize to trainees at Emory, both students and residents, and I'll emphasize to those of you even outside metropolitan areas, that health issues for lesbian and gay people in this particular slide, but LGBT people more generally, are relevant and apply no matter where you live or work. So even in rural areas outside of big cities, LGBT health issues are of importance. So what is LGBT health exactly? The federal government here in the U.S. has helped us better understand that, and up until now it's been defined as disparities that may disproportionately, health disparities may disproportionately affect LGBT people. The Institute of Medicine looked at this over 20 years ago with a landmark report on lesbian health. And because of the limitations in the literature, the fact that there's not a lot out there, the main conclusion of this report was that more research needs to be done, and we have to have better methods of conducting that research. Many of you are probably familiar with Healthy People 2010. It's the public health blueprint for the U.S. And in 2000, was the first time that the Department of Health and Human Services included sexual orientation in data tables as an identity or a characteristic upon which to collect data over the next 10 years, with the goal of eliminating health disparities that occur due to differences in sexual orientation. That call and that need to collect data related to sexual orientation was reemphasized in 2010 when Healthy People 2020 was released. And I want to give it a bit more detail on the landmark Institute of Medicine report in 2011. Before I get to that, I want to highlight the limitation in the information we can present here today to you. A study was done in 2009 that looked at the medical literature related to human health as indexed in PubMed. And when that was, when the study was done, the authors noted that only 0.21%, less than 1% of all publications related to human health included an LGBT-related keyword. So it makes sense then that there's limitations in us fully understanding the disparities that may disproportionately affect LGBT people. Well, why is this? As Gall has already detailed, sexual orientation is complex, gender identity is complex, and both can change over time. So how does a researcher, whether in the medical or sociological fields, accurately assess an individual's orientation or identity? And as you might imagine, people are going to be reluctant to answer truthfully questions that are very sensitive and personal. For those of you who do public health or epidemiological research, it's very resource intensive to study minority populations, and so it can be difficult to find funding then to best understand and research LGBT populations. For the studies that we do have, there are limitations in those data sets because many times non-probability samples are used. So convenient samples and snowball sampling are two examples. So the 2011 Institute of Medicine report, one of the most comprehensive resources out there for the current status of LGBT health and health-related research. I encourage you, those of you on the webinar, to order a copy from the Institute of Medicine website if you don't have it already. So the conclusions of the authors and then the committee were as follows. And number one, NIH should implement a research agenda designed to advance knowledge and understanding of LGBT health. So as the previous slide mentioned, we need, not enough research has been done. We need the lead research agency in our country to ask for more researchers to be studying LGBT populations. One great service that the federal government provides in understanding the health of our population is collecting data through regular federally funded surveys and through electronic health records like the VA system. So a call to action here was including data on sexual orientation and gender identity in these surveys, and to ask this information of patients when they come through the health system. And finally, finally on this slide, there needs to be standardization of measures. So the way that researchers ask about sexual orientation and gender identity needs to be consistent. The committee members had three more goals or action items for the research community. Support methodological research that relates to LGBT health. What's the best way to understand LGBT populations? The NIH also recommended, the Institute of Medicine also recommended to the NIH that there be a comprehensive research training approach to doing this health research, so that we need to be training more young researchers in the best methods to investigate this population. And encourage NIH grant applicants to address whether they are or are not including LGBT populations in the samples that they're people that they're studying. So why this focus? LGBT people are human, just like anyone else that I would encounter in the healthcare setting. So what makes this different? What makes LGBT health unique? Well, there's multiple additional factors that negatively impact the health of LGBT people. These things are not unique to LGBT people, but they disproportionately affect health outcomes. So examples are history, stigma, laws and policies, barriers to patient-centered care, and demographic factors. And I'll go into more detail on each of those. So starting with history. Well, until 1973, homosexuality was actually pathologized by psychiatrists. It was at that, in that year that the American Psychological Association removed homosexuality from the Diagnostic and Statistical Manual as pathology, as disease. This is a picture from that meeting back in 1973 of the APA, and this was a very closeted gay psychiatrist who, because of fear of repercussions of being out and disclosing his sexual orientation to his community of colleagues, that he would be ostracized and may even lose his ability to practice. This also speaks to discrimination even within the profession of medicine and other health professions. Transgender identity has been pathologized and has remained pathologized in the most recent version of the DSM, which is version 4R. DSM-5 will be released shortly. So the effect of pathology, of pathologizing identity, can't be underestimated, and how it negatively impacts the health of transgender people. Stigma, again, not unique to LGBT people, but disproportionately affects LGBT people. When a survey of secondary school students was done by the Gay, Lesbian, Straight Education Network, or GLSEN, back in 2008, overall 4.5% in the sample reported harassment. A similar survey was done by, the same survey was done by GLSEN again in 2008, and look at the striking difference that LGBT students report in public schools. 22% reported being physically assaulted, double that experiencing physical harassment, and well over 3/4 of LGBT students reporting verbal harassment. So again, a striking difference between non-LGBT identified and LGBT identified youth and students. Unfortunately, no federal law prohibits harassment based on sexual orientation or gender identity in the schools or otherwise. Family acceptance. Family acceptance, as you might imagine, leads to better health outcomes, both mental and physical, for youth, and the opposite is true too. And there is data to support this, that LGBT youth whose families do not accept them experience more depression, substance use, and suicide. And the youth pictured here is one of the many who's been reported on the public press who took his own life when facing bullying related to his identity in school. So the converse, we hope, will be true and protective for youth in the future, that those who are more accepted by their family will then have better health outcomes, less depression, less substance use, and less suicidality. So laws and policies. So there are many discriminatory laws and policies that exist in the United States. And when researchers have looked at states where marriage between same-sex couples is legal, they've identified that those same-sex couples have less depression and stress and find more meaning in life. So despite that literature, there is federal law, the Defense of Marriage Act, which many of you are familiar with, that prohibits the federal recognition of civil marriage. And many people don't realize this, but civil marriage, federal civil marriage, grants access to many rights and privileges, well over 1,000, including immigration, protection and benefits, survivor benefits, access to the Family Medical Leave Act laws, visitation rights in hospitals, HHS regulations, new HHS regulations now protect same-sex couples in that regard, and employer-sponsored health plans. So to emphasize that point more, if your partners or your own, sorry, if you go back to the previous slide there, if your partner, your loved one, or you yourself don't have access to employer-sponsored health care, it makes sense then that your health outcomes are going to be affected. So the Defense of Marriage Act is an active issue in the legal community right now. So more to come on that. So accessing, sorry, Gall.
Oh, I was gonna take over from the slides. Oh, sorry. Yeah. I apologize. Go ahead. Sorry, it's our first time presenting this, so we're still getting the handoffs here. So thanks, Jason. And continuing with that, with the theme of the barriers to care, there's also healthcare access issues. We know that gay men, bisexual, and transgender people, and possibly lesbians, although the data is less certain about that, have lower incomes than what we call straight gender conforming people who have similar educations and occupations. So what happens is that LGBT people start with lower incomes. Then there's a lack of federal marriage recognition, which creates tax and insurance differences. So, for example, even if you work for an enlightened company that offers that may count your same-sex partner as family for the purposes of insurance, you have to pay federal taxes before you're able to pay for the family premium. And if you're married and heterosexual and married, and your marriage is recognized by the federal government, the premiums for your family's health insurance come out of your income before they're taxed. And if you're not married, according to the federal government, they come out after. And you also cannot file federal income tax as in a joint fashion if your marriage isn't recognized by the government. So LGBT people start with lower incomes and then wind up with less disposable income because of these tax and insurance differences. And there have been polls to show that LGBT people are also less likely to be insured than their straight gender conforming counterparts of similar socioeconomic backgrounds. And I can tell you, I work in a clinic, in a health center that serves uninsured people and focuses on the LGBT community. And our health center, the rates of 40% of our patients don't have insurance, and that's considered very high. In other health centers in New York State, the rate is closer to 25 to 30%. So we see it's a huge impact that LGBT people do not have insurance and are less likely to be insured. And then, of course, if you happen to be transgender and you are insured, there's a very good chance that your insurance plan will specifically exclude transgender coverage. So a lot of insurance plans, even though the hormonal care and the surgical care is so vital to a transgender person's identity and mental health and sometimes physical safety, most insurance plans still consider it a cosmetic issue, and it's far from cosmetic. And so while that is changing slowly, you're still more than likely to end up with insurance that will not cover transgender care. Another barrier is healthcare provider attitudes. there have been many studies of different types of providers at different levels of training: doctors, nurses, physician assistants, students, trainees, residents, and they've consistently shown that prejudice against LGBT patients is unacceptably high. It is improving with time, but it's still unacceptably high. And just as an example, we found these physician attitude surveys that were done by the same person 20 years apart, so they're really interesting. And in 1982, physicians who answered this survey said 46% said they would discontinue referrals to a gay pediatrician, and so almost half in 1982. And 17 years later, in 1999, that number was only 9%. So that's still 9% too high, but it's far better than 46%. And in 1982, almost 40% of physicians answering this survey expressed that they are uncomfortable providing care to gay patients. And 17 years later, it's only dropped down to half of what it was, and so 20% are still uncomfortable providing care to gay patients. That might be because they're uncomfortable with gay people, but it might also be influenced by the fact that LGBT health is really not taught in education. We also know that being in the closet, GLMA used to have a slogan, the closet is a health hazard. We know that being in the closet or not feeling like it's safe to come out and be who you are with your medical provider can have an impact. This is a 1998 study that showed that lesbians who are out to their primary care provider are more likely to seek health and preventive care, more likely to have a PAT test, more likely to not smoke, and more likely to feel like they can discuss difficult issues with their provider. So a provider attitude and level of acceptance can have a direct impact on the patient's health. And then the training. The training is just not there. Recently, last year, JAMA published an article, a survey looking at medical schools in the United States. 132 medical schools responded to this survey, and they asked about LGBT content in medical school curriculum. And the median time for LGBT content was 5 hours in all of medical school, where it was even marginally mentioned, and mostly in relationship to HIV and psychiatry. So not talking about the issues that we're going to talk about a little bit later today. And notably, there were quite a few schools who had absolutely no LGBT content in their curriculum. There were 9 schools that had no mention of LGBT content in the preclinical curriculum, 44 schools that didn't have any LGBT content in the clinical years, and 5 schools out of the 132 that had no mention of LGBT content at all during any part of the medical school. There are also some demographic variables that make LGBT people different. One of them is family structure. LGBT people are less likely to be parents. There are a lot of gay and lesbian couples and transgender people who are having more children and raising them, but statistically they are less likely to be parents. And when we talk about the specific differences, we'll see how that impacts their health. But it's important to also know that the lesbian and gay couples who are raising children, they have looked at children being raised by lesbian, gay couples, and transgender people, and they have found that overall they're very well adjusted and developmentally similar to those of their heterosexual and non-transgender peers. So being raised in a gay or lesbian household does not have a negative impact on children at all. There's also this idea of the multiple minority status. The social determinants of health that are traditional obstacles to care that everyone's pretty much familiar with are really magnified in people who are also LGBT or T. So if you're in a minority racial or ethnic class and also gay, there is a likelihood that you are not only experiencing the fallout of being a minority, a racial minority in the United States, but you may also be experiencing ostracization by your own racial and ethnic community, and being marginalized even further. The same is true with low income, low education, immigrant status. Remember, immigrants that are partnered with LGBT people cannot get married in the United States and gain citizenship that way like heterosexual people can, and limited English proficiency. So anything that gives you a disadvantage or is isolating or marginalizing in our society will just magnify the experience of being LGBT. In a review in the Journal of GLMA in 1997, Cato Hanlon looked at the medical consequences of homophobia and reflected them in this figure, which, for those of you familiar with Maslow's hierarchy of human need fulfillment, it's basically, you go up the pyramid with the things that are most basic to people, and if you cannot fulfill the most basic needs, you're never going to get to the higher ones. So the first and most important thing is food, water, and safety from violence, and then shelter, warmth, money, job, and then community, career, and comfort, and finally intimacy and family. And you have to have the layer underneath in order to achieve the layer above. And Kate put the issues that LGBT people are facing specifically, and so on the very basic level, there is more verbal and physical violence against LGBT people. On the shelter level, there is housing and job discrimination that is still very much legal. There's in many jurisdictions. On the community level, you may not be accepted by the community that you were born into. There are family, religious, and issues there, and societal disdain. And then on the intimacy and family level, it's really difficult. It's very delegitimizing not to have the same rights and protections and privileges that other married people do, and the same is true for adoption. So at every level of this Maslow hierarchy, LGBT people might face discrimination and disadvantage. But Kate also had, Kate also talked about how homophobia plays a role in all of this. So the absence of civil rights, the invisibilization of LGBT people, because unlike racial minority status, you can't tell by looking at someone that they're LGBT, and societal misinformation can result in shame, fear, isolation, a suppression of your true feelings, hiding, a low self-concept, a lot of stress, depression, and loss of motivation, which of course, this is the experience of marginalization in our society, can result in really poor health outcomes because of health habits. You may avoid going and getting care, not get the screening that you need to, not present for care until you're relatively advanced in your disease, have a low compliance because of not feeling very related to your healthcare provider. And of course, all the things that go with poor psychological health and low self-esteem, which could be suicide, depression, unsafe sex, and substance use. We'll go into that in more detail coming up. So I'm going to turn it back to Jason to start talking about the actual clinical differences in LGBT populations.
Thanks, Gall. So as you might imagine from what Gall just went through, that clinical outcomes could be negatively impacted for LGBT people. So the following sections that that Gall and I will cover outline many of the differences that have been demonstrated by studies. I've already mentioned the limitations in the data that we have out there, based on the study that was done looking at the medical research in the past. The source for the most current source for LGBT health research and health status comes from the Institute of Medicine report that I've highlighted already. As the authors say in that report, LGBT people face the same full range of health risks, but they also face a profound and poorly understood set of additional health risks due largely to societal stigma, social determinants of health, as Gall mentioned. Now, before I go on to more health issues affecting specific populations, I do want to emphasize that the majority of LGBT people that you will encounter in healthcare setting, in everyday encounters are very healthy and happy. And the goal of the mission of GLMA, of our organization, and the effort in educating all of you here is to help maintain wellness and resiliency for LGBT people out there. And to do that, we do need to, though, understand how health can be negatively impacted by stigma and homophobia and transphobia. So LGBT youth are at higher risk of harassment, victimization, and violence. I already mentioned the study comparing LGBT-identified youth compared to the larger population. It's also experienced by youth perceived to be LGBT. So whether or not someone actually has a lesbian, gay, or bisexual orientation or a gender variant or gender nonconforming identity doesn't necessarily mean that they will or will not be a victim of violence or harassment. It's really the perception of that. And as you might imagine, if you fear going to school or if school is a stressful experience, you may have lower grades. I mentioned before acceptance. Many LGBT youth are not well accepted by their family, and there's pretty good evidence that there's a disproportionate of LGBT people, youth, among homeless young homeless populations. We don't have data right now that looks at transgender men. If you're not accepted by your family, you're more likely to be abused by people in your close social networks. Unfortunately, childhood physical abuse can be a manifestation of this. So mental health for LGBT youth, it goes then that if you are a victim of harassment in your school, you're not accepted by your family, there's going to be negative mental health consequences, including a higher prevalence of depression, suicidal ideation, and attempts of suicide, particularly if you are rejected by your family. If you don't have a good internal view of yourself, that can be manifest also in how you view your physical appearance. So many youth, especially young gay youth or young men who have sex with other men, have a higher prevalence of disordered eating compared to their heterosexual counterparts. Another consequence of a negative consequence of stigma, discrimination, harassment in larger society are substance use and misuse. So that includes smoking, alcohol consumption, other substances where there's pretty good data to support higher prevalence of these among lesbian, gay, bisexual youth. There's a higher prevalence of HIV, particularly among black men who have youth and transgender women. Really, when you look at where the epidemic has turned, it's among communities of color and particularly among LGBT communities of color. Interestingly, unwanted pregnancy rates may be just the same or even higher for women who have sex with women than compared to heterosexual women. And that's an important tangential point that the supermajority of identified lesbians have male sexual partners during their lifetime. So this particular fact emphasizes that point. getting back to the internal view and how that manifests in views of your physical appearance, lesbian-identified youth may have elevated BMIs compared with heterosexual young women, again because of challenges and disorders with eating. If a woman who has a lesbian or a bisexual identity fears going to see a healthcare provider, that's going to affect utilization of preventive health services. Gall already mentioned how little is taught in medical schools about LGBT health, and if providers don't know enough about the needs of LGBT people, this can be the end result.
Jason, I'm going to jump in here. I'm sorry. Jason and I, you guys should know that I'm sitting in New York and Jason in Atlanta, and I can't cue him when we're switching speakers, and I'm the one who came up with switching the speakers, so it's something that we'll have to work on for our next presentation. So I'll continue the discussion about LGBT adults and then turn it back over to Jason when we talk about older adults. I do want to take just a minute to talk about something that came up today that isn't, we don't have a slide about because it just came out today, but it is incredibly relevant to this conversation. Our Executive Director, Hector, already mentioned that the Department of Health and Human Services has put out a report for their 2012 objectives around LGBT health. And I want to just highlight a few things that they're planning to do this year because they mesh so nicely with the issues that we're discussing today about the health differences between LGBT people and non-LGBT people. So among, I'm just going to mention a few. One of the things that the HHS is committing to doing this year is that the NIH, the National Institutes of Health, is going to respond to the Institute of Medicine report from last year by releasing a report that identifies the specific gaps and opportunities in its own portfolio when it comes to biomedical research on LGBT health. So our federal government is committing to addressing the research disparity. The Ryan White HIV and AIDS programs has a special project of national significance, that's what they call it, that is going to award 8 organizations to develop, implement, and evaluate interventions that will improve entry and retention of transgender women of color into HIV care. So we'll talk about how transgender people are disproportionately affected by HIV. You know, right on the heels of what Jason just mentioned about lesbian women's BMI, the HHS Office on Women's Health is going to fund some pilot studies to test and identify and test effective and innovative ways of reducing obesity in lesbian and bisexual women. So our federal government recognizes that this is a specific issue. We'll talk about domestic violence in a second, but starting this year, the CDC is going to start releasing data from its National Intimate Partner and Sexual Violence Survey that is going to be categorized by sexual orientation. So the CDC is committing to looking at intimate partner violence and sexual violence by sexual orientation. The FDA is going to launch multiple advertising programs to a host of youth and young adult audiences who are at risk of using tobacco, and they're going to focus on priority populations, which includes LGBT youth. SAMHSA, which is the Substance Abuse and Mental Health Services Administration, is going to disseminate tools to behavioral health and primary care practitioners to help them assess, treat, and refer LGBT clients in a culturally competent manner. So there's an acknowledgement that substance use may be different in LGBT populations. The Administration for Children and Families is going to establish core competencies for runaway homeless youth programs that are inclusive of sexual orientation and gender identity considerations. So that's an acknowledgement that youth are disproportionately affected by homelessness and being runaways when they're LGBT or T. And finally, the Center for Medicare and Medicaid Services, known as CMS, is going to release a training video to educate people who do long-term care on the specific long-term care needs of LGBT older Americans. So it was exciting for us that this report got released today with all of these agenda items that so nicely overlap with what we're talking about. So back to adults, we know that, as Jason mentioned, lesbians and bisexual women are just less likely to utilize preventive health services. Continuing through all ages, LGBT people remain targets of stigma and discrimination from the time they're identified as LGBT and through every age. Hate crimes continue to be a problem. The FBI in 2006 reported 1,472 anti-LGBT hate crimes, and the National Coalition of Anti-Violence Programs recorded in 2007 that they had heard from 2,340 victims of anti-LGBT violence in 1 year. The lifetime risk of a sexual assault for a lesbian, gay, or bisexual person is 2 to 3 times higher than a non-lesbian, gay, or bisexual person. Transgender women who are sex workers are at higher risk of sexual assault than non-transgender women who are sex workers.
And Gal, we had a quick question. When you're saying transgender women, are you talking male
to female?
Okay, thank you.
Yes.
Thanks for that clarification.
Mm-hmm. There is limited data that suggests that intimate partner or domestic violence among lesbian, gay, and bisexual people is comparable to non-LGBT people. And I can tell you anecdotally, although I don't think that there's a lot of data on this, that the rates of domestic violence in transgender women, in my experience, is also very high. So I'm very grateful that the CDC is going to start looking. I mean, they're not talking about gender identity, but they're going to start looking at those numbers divided by sexual orientation. In terms of mental health, the higher prevalence of depression and anxiety continue through adult life. There is not a lot of good data on transgender people, but lesbian, gay, and bisexual, there's good data to show that there's a higher prevalence. The disordered eating continues among men who have sex with men. We use men who have sex with men as sort of a shorthand to a shorthand. Instead of saying gay and bisexual men, it's just any man who has sex with other men. There is comparatively less research on lesbian and transgender women, people. Along with the depression and anxiety, there's a higher prevalence of suicidal ideation and attempts, and that's true for lesbian, gay, bisexual, and transgender people. There's a very frightening statistic that in a survey of transgender adults that had a few thousand respondents that showed that more than half of the respondents had contemplated or attempted suicide at some point in their life. The national suicide rate is like 1%, so that's really high. But it's also important to know when we talk about mental health that there are studies that show, data that show that the vast majority of transgender patients who undergo genital surgery are satisfied with the results. And I think that a lot of times when people talk about genital surgery, they're very concerned about rates of regret and things like that. And there's really good data to show that the overwhelming majority of transgender patients, their mental health actually improves after genital surgery. LGBT people are twice as likely to smoke than heterosexual people, and it's interesting that there is this concept that bisexual people may be in a double closet because they are not straight and they identify as bisexual, but there's also some internal shunning in the community that the concept of bisexuality and bisexual people are not universally embraced by lesbian and gay people, unfortunately. And so being bisexual can sometimes be even more stressful than being lesbian or gay. And there are some studies that show that bisexuals may actually have a higher smoking rate than lesbian and gay people. Women who have sex with women, meaning lesbian and bisexual women, have more alcohol and illicit drug use than heterosexual women. That's been shown in a few studies. And again, there's that stress of being bisexual. The bisexual women may actually have even higher rates of use than lesbians. And unlike in the general population, one interesting thing that's about lesbian and bisexual women and substance and alcohol use, whereas in the general population that behavior, the problem extinguishes as people get older, there's some studies that show that it may not decrease as much with age as it does in general population for this group. Men who have sex with men have higher use of some drugs, mostly the drugs that are associated with club drugs like ecstasy, cocaine, GHB, drugs that are used recreationally. And there, a lot of the better studies that look at alcohol use shows that men who have sex with men may have similar alcohol use as heterosexual men. But of course, any drug or alcohol use can result in worse health outcomes because it leads to increased sexual risk-taking and HIV infection. There is some limited data that suggests that substance use rates are high in the transgender population as well. But it's a very, very, very understudied group, transgender people in general, so our data is very limited. And we do have some studies that show that specifically when we talk about injection drug use, that transgender people have higher rates. But those include injecting hormones that are not legally obtained, and the injection of silicone, which is can be a big problem in the transgender community as people go to sort of extreme measures to modify their body out of desperation to feel better about their appearance and get these illicit injections of sometimes industrial grade silicone, which can cause a host of problems, not the least of which are infections spread by unsafe injection practices. So moving into the more medical issues, everybody knows that HIV and AIDS are much higher rates in communities of men who have sex with men and transgender women, particularly among communities of color. Today, gay men are the only demographic group that is increasing in the number of HIV infections every year. And that's particularly true among young gay men and young gay men of color and among transgender women. STIs, we talked before about a lot of the demographic differences between LGBT people and non-LGBT people. There are also some behavioral differences, and there's particularly when it comes to the mechanics of sex between men and sex between women is not mechanically the same, of course, as sex between heterosexual couples or opposite-sex couples. And because men who have sex with men tend to have more partners than heterosexual men, there's a higher risk of sexually transmitted infections among that population. There's a real ignorance or very limited understanding by medical providers about sexual transmitted infections that are transmitted by female to female sex. And in upcoming modules of this webinar, we will go into more of that. And there's very limited data on STI risk in transgender people. As Jason mentioned, in the youth, in adults, the women who have sex with women may also have a higher risk for obesity and higher BMIs. Men who have sex with men, especially those with HIV, have higher risks of anal cancer. This is a growing area of research and screening and prevention guidelines. There's very little data on the longer-term risks of hormones in transgender people, although the little bit of data that we have shows that it's generally safe. And I'm going to turn it back to Jason to finish out the module with the older adult risk.
Thanks, Gall. So yes, looking at older adults, as with middle-aged adults, elders are less likely to seek health services compared to the general population. They face continued stigma, discrimination, victimization, as do youth and adults in middle age. One interesting thing to consider, they're less likely to have children and receive care from adult children. So that can be a barrier to good health and wellness as you get older. There's also very little data on what happens to adults in long-term care facilities. There are LGBT-specific nursing and elder homes that are now becoming more popular. And unfortunately, there's some bad stories of discrimination specifically in older elder homes where long-term same-sex couples have been separated or face discrimination otherwise. So wellness and health in older age is likely intimately tied with resilience and being able to manage crises. There are negative health outcomes because of this discrimination in older age, specifically higher rates of depression. Particularly with lesbian and gay elders, we don't have a lot of data for bisexual and transgender elders. For women, there is an under-recognition of cervical cancer risk in adult lesbians, and really no matter what age, and also in transgender men, also in other words, biological or genetic women that have a male gender identity. And I'll make the point I did already that the supermajority of lesbians have sex with men in their lifetime, and so the same guidelines that apply for cervical cancer screening apply to lesbians and transgender men as well. There's a concern that women who have sex with other women may have a higher risk for breast cancer because of an increased incidence and prevalence of risk factors, and also because of not seeking preventive health services. There's very little data out there for transgender men and women and their risk of breast cancer. There's conflicting data on whether lesbians are at a higher risk for cardiovascular disease. The concern for it is that there are increased risk factors for such, particularly obesity and smoking among lesbians. We really don't understand the long-term use of cross-sex hormones for transgender people, and so that's going to disproportionately affect older transgender people as they age. Few prevention programs are aimed at older people, LGBT people with HIV and AIDS, but they remain at risk. So to end our webinar, present some nice happy pictures of LGBT people out there, and that's a good way to end. That the supermajority of LGBT people that you encounter in the healthcare setting are going to be healthy and happy. And I hope our webinar today has given you some food for thought on how you and your role in healthcare can help maintain health and wellness for LGBT populations.
Great, thank you. I'd really like to thank both Gal and Jason for a very informative webinar. And now we're going to turn it over to our Q&A session. I already have a few questions, and one question that I've been getting repeatedly is that will there be a downloadable version of this webinar available? So we did record this webinar, and both the link to the recording and the presentation slides will be posted on both the GLMA and the Hopkins Center for Health Disparity Solutions websites. In addition, people were asking, they said they'd like handouts and reading, and so we anticipate that over the course of this cycle of webinars that we will be developing a resource list. And we did say this was the first of a 4-part webinar series, and so we have a potential schedule for the rest of the series. So we anticipate part 2 of the webinar series being held in October after the GLMA annual conference. And again, I'd like to reiterate that is being held from September 19th through September 19th through the 23rd in San Francisco. Part 3 would be in February 2013, and part 4 in April 2013. And more information will be forthcoming on GLMA's website as well as our center's website. And we also had another question about whether we will be offering CEs for the webinar series. At this time, we will not be, but CEs are offered as part of the GLMA annual conference. So let me turn to a few of the other questions that we have received. One person said that he had read in a psychology book that the hippocampus of homosexuals is different than a heterosexual of the same sex. Is this true?
Hi, it's Gal. So there is a growing area of basic research that is looking at very basic granular differences between LGBT people and people who are heterosexual and gender conforming. And there are a few themes that emerge about what might be some biological differences. But it's not clear what's cause, what's effect, why they form, how they form, or what role they play. But there's a whole bunch of interesting statistically significant differences in things like finger length and hippocampus size and all that. It's really it's very interesting, but it doesn't. It's a very basic research question. It doesn't really impact, the ability to deliver competent health care to LGBT people.
Great. Thanks, Gal. I appreciate that response. We have a question from Janet Harding, and she has a question. You had made reference to the NIH response that I believe just came out recently. I know Department of Health and Human Services was today. She was just wondering, where would one go to get additional information about that NIH response?
There is on the HHS website. If you give me a second, I can tell you. Hold on one second.
Or if it would be easier, if you could provide us with that link and I could post it and send it to Emily as well for posting on the GLMA and our websites as a resource?
Sure. Yes.
Sure, that would be great. Thank you very much. Let's see. We do have someone who has her hand. Okay, let me take two questions by phone. I have Emily Lung, who's had her hand up for the entire webinar. Emily, are you able to hear us?
Your arm must be so tired.
Yes, yes. Her hand's been virtually up for almost the entire webinar. So Emily, go ahead. Emily, can you hear us?
Oh.
Yes, hello?
Hi, sorry. I didn't mean to raise my hand. I didn't have a question.
Oh, you did not? Oh, okay. No problem. Thank you.
Sorry about that.
Not a problem. Thanks. I do see that Thomas Long does have his hand raised. So, Thomas, I will unmute you.
Yeah, thank you. The question, and I just sent it to you as a text, regards politics. Many of these federal priorities depend on funding. Funding depends on which party controls the Congress, and the initiatives depend on which party controls the White House. So my question is, how vulnerable are these really important initiatives at the federal level to future changes in electoral politics?
I will just say very vulnerable.
Yeah.
I think that's a very good point.
Great, thank you. We have another question that says, regarding the FBI data on hate crimes and the increased number of reports each year, what are your thoughts on why this number is increasing? Are more people reporting, or are there actually more crimes? Are numbers increasing as there is more publicity and push toward marriage equality?
So let me just, I don't know if Jason stepped away for a second, and I don't know if he's back yet, but let me just clarify one thing. If we go back to that slide, which is...
yeah, I'll flip back a couple slides.
Yeah,
so.
It's actually not, it was two different sources in 2 different years. It's not a trend where there's more in one year than the rest. It's the first one, the lower number, was an FBI, what the FBI reported in 2006, and then the second was an advocacy group that reported in 2007 how many different people complained to them that they had been, they'd had violence inflicted on them that was LGBT bias related. So I don't, actually, it's a great question that I don't know the answer to, what is happening to this number and whether it's going up or down. But I wanted to clarify that in the slide, we weren't trying to make the point that it increased greatly from one year to the next. It's just two examples of reports that show how widespread it is.
Okay, thanks for that clarification. I apologize. On the fly, I wasn't able to get to that slide very quickly. Great, thank you. So the next question I have is men who have sex with men also used, or MSM, also used for men who don't necessarily identify as gay?
Yeah, that's a great question and something we should have made clear in the slide. So when we talk about gay or bisexual men, going back to our earlier definitions, we're talking really about identities. We're talking about how people call themselves. And when we talk about men who have sex with men, we're talking more about behavior. So when you talk about biological medical risk, it's easier to talk like HIV and sexually transmitted infections, for example. It's easier to talk about the behavior that puts you at risk for it. So we talk about men who have sex with men, but when we talk about the risks that are incurred by marginalization, then I think it becomes more relevant to talk about identities and how people label themselves and how they live, whether they live as an openly gay person or they live as a straight person who's just having sex with men, which may be more stressful or less, depending on where you live, or as a bisexual person. So hopefully that clarifies why we switched back and forth. We didn't really make that very clear, and I want to thank you for that suggestion.
Great, thank you, Gal. The next question is, where do intersex individuals fit into all of this?
Right. So intersexed they're now commonly referred to as disorders of sexual differentiation, and intersexed are medically a little bit different than LGB or T people in terms of what they are medically at risk for, and I can't speak for Jason, but I'm certainly not an expert in disorders of sexual differentiation. But it is true that people who are intersex often consider themselves to be under the LGBT umbrella because of the the shared commonalities that they may have. They may feel like a gender minority or a sexual minority. They may suffer from stigma and discrimination and may feel alone and have fallout from that type of marginalization. So they're sometimes grouped in, but medically they also have different concerns.
Great, thank you. So the next question is, it says it may be geared more towards public policy, but the person's wondering if you're aware of any efforts to reverse the mandate that says men who have sex with men can't donate blood.
Yes, that's a great question. There is actually a lot of movement afoot. I'm not up to the minute on what the latest is, but there's a lot of movement afoot in the federal government to take a look at that policy and reevaluate it. There have been most other countries in Western Europe have reversed that ban on blood donation by men who have sex with men, and they have changed it to not having, because right now in the United States it's since 1977. So if you've had sex with another man, if you're a man who's had sex with another man since 1977, you're not legally eligible for donating blood. But they're looking at, they're starting to look at more rational policies, like, in the last 5 years and HIV tested and stuff like that. So that is a policy issue. I happen to know a little bit about it, but it's something that's being challenged as we speak, and in my opinion, very, very correctly so.
Excellent. Thank you, Gal.
Is Jason back, by the way?
Jason, have you made it back yet? No, I just saw his note. So, okay, next question is, where can I get material from my pediatric office to convey to our patient population that we are a safe zone, the youth themselves, and same-sex parents?
Well, I love that question. That's a great question.
Excellent question.
And I, let me look into that and try and find something and mail it back to you, Sherry. If you could take the name of that person,
Yes.
or we can post it, because at my health center we have an adolescent clinic, but it's not really pediatrics, and I think there are resources for pediatrics for LGBT affirmative environments, but I'll have to look into that.
Right. I do know, Gal, from having been an LGBT faculty moderator at a university, we did have stickers and training about areas being safe zones, different offices and different places. I don't know if that's something that could directly translate over to the clinical setting, but I could send that to you as well.
Yeah. I mean, I think, yeah, sure. And let's look into some specific LGBT-specific educational patient brochures.
Right. Okay. That would be great. So I'm going to take a few more questions here. One says, on the early slides, about 7% of men had same-sex attraction, but over 9% had same-sex activity since childhood. How would this data be interpreted?
Well, this was... this was a study done in 1994, and I don't know if there's a statistical difference between that 7.7 and that 9.1%, but there are definitely reports of male-to-male sexual contact among adolescents that may not be linked to attraction, that may be linked to other things like peer pressure or potentially abuse in childhood or just experimentation. So it just highlights again that what's going on in people's fantasy lives can be very different from how they're behaving, and that can be very different from how they're identifying in society. And I think it really just underscores that you have to ask the right question. You can't ask someone if they're gay and assume that they're not having sex with other men because they answered no.
Right.
You have to ask, have you had any sexual partners that are male?
Right. Excellent. We have another minute or two, so I'm going to ask a few more questions. Next question is there any way we can directly work or volunteer to increase the quality health care for LGBT communities?
Absolutely. I think the most work you can do, I work in a health center that is in Manhattan, and less than 50% of our patients live in Manhattan, which means that every day, and we're in New York, it's a very, healthcare rich area of the country. Every day people come here who literally pass hundreds, if not thousands, of doctors' offices on their way to our health center in order to get LGBT affirming or competent care. And so I think the most that you can do is start in your own environment and your own office by getting educated, like with these seminars, with these webinars, getting educated on the issues, understanding more, reading up about it, going to resources, and then informing patients by putting LGBT information in your waiting room in your areas that you are open-minded, you are welcoming, you are committed to providing competent care. And I can't imagine what's more powerful than just the difference you can make in your own place of work.
Excellent. I'm going to take one last question, and then Gal and
good, and
Jason.
Jason's back, so
he
he
is
can
back.
answer
Oh,
this
yes.
one.
Hi, Jason. Glad to hear you're back. Great. So this next question is, you mentioned there being an intersection between racial and ethnic minorities and the LGBT community. I know there's a fair amount of literature regarding gay, bisexual, Hispanic, and African American health issues, but are there any prevalent issues within the LGBT Asian community of which you're aware?
I'm not familiar. I'm trying to think of specific health issues that are relevant there.
I can take it if you.
Sure, go ahead.
So there is a lot of stigma and tradition in traditional Asian communities, at least here in New York. I'm sure that it varies widely, but the biggest issues for people who have a very strong, come from a very strong, tightly knit ethnic community are usually ones of acceptance and rejection. And I know that we have a clinic here in New York that really tries to specialize in the healthcare needs of LGBT Asian Americans, and social isolation, rejection from the community, rejection from family is a recurring theme that comes up. Not to say that that's true for everyone. There are certainly incredible accepting people and accepting families everywhere, but it's always, when you grow up with a minority status and you're in a community, a tight community that may or may not accept you because you're different, the stigmatization is always a huge issue, and that stigmatization or marginalization absolutely can result in more risk-taking, more depression, more mental health consequences, and poorer health outcomes.
Great. I want to end with, we have a request actually, and the request is there any chance that the information from this webinar will be converted into a manuscript or series of manuscripts or even a journal supplement that could be in the peer-reviewed literature to allow this information to get out in one simple place?
Well, a lot of the information that in the second half, where we talked about the health disparities, is actually directly from the Institute of Medicine report. So that report that Jason showed you the cover of and went over is a fantastic, you can download a PDF for free, or you can order the book from the Institute of Medicine by going on their website, and we can provide that as part of the resources. But it's all right there, so at least most of it is, and it's very well annotated and researched. So I feel like someone's already kind of done that. And then we're going to archive this webinar, and it's recorded, so if you wanted to write a script, you could just listen to it.
Right. Yes, absolutely. So the good thing is that the archive is available for 12 months. So again, that will be posted on both the GLMA and the Hopkins Center for Health Disparity Solutions websites, along with the slides. And the last question, or the last point I'll make, is that yes, when we do have the dates finalized for the remaining 3 webinars in this series, we will send that information out first to those who registered and participated in today's webinar, as well as our regular places that we send the information. So I know we're over time. Oh, go ahead, Paul.
I just want to put a plug in, for those of you who are still on. I think we're going to be sending out evaluations, right?
Yes. In fact, yes. About an hour after the webinar, you should be receiving an email thanking you for attendance, and there will be a link to complete a webinar evaluation. So, Gal, thank you so much for that reminder. So we really do appreciate your feedback. I will take the remaining questions that came in, and I will forward those on to Gal and Jason. And there were a number of people who also remarked they'd like to get information about the safe zone and some of the other items. We will post that on both sets of websites, so they'll be accessible to everyone. So
fabulous.
Again, thank you for your time. I'd like to thank Gal, Jason, and Hector again, and I look forward to the remaining webinars in this series.
Thank you, everyone.
Take care.
Thank you.
Yep, bye-bye.